Welcome everyone to this tutorial on IV fluids. My name is Ramesh and I'm a resident in Nepean Hospital. IV fluid prescribing is a really important skill to have as an intern. What I hope to provide you guys with is a framework that's practical and fairly straightforward to use. The way I'll approach this is to firstly go through some of the common types of IV fluids, as well as some definitions you'll see thrown around. I'll then go through how to prescribe fluids and electrolytes for a fasting patient. This will provide us with a good framework that we can build on for the rest of the tutorial. I'll go through some of the basics of electrolyte replacement, and then we'll go through some case examples to apply what we've learned. So here's a list of some common types of IV fluids you guys will see. 0.9% normal saline. This is what people tend to call normal saline on the wards. There's Hartmann's, which is a surgeon's favorite. You then have 0.18% normal saline, which is just 1/5 of what normal saline is. 4% dextrose and 0.18% normal saline is what we call 4% and 1/5 colloquially. You've got 5% dextrose, which is commonly used with infusions together with insulin. And then there's plasmolite, which is perhaps the most physiological of the lot. Given that it's expensive, it's predominantly only used in the ICU setting. I want to talk about a couple of terms you'll hear being thrown around, crystalloids and colloids. So fluids that are crystalloids are basically just aqueous solutions of salts and small water-soluble molecules. All the fluids above are crystalloids. Colloids are any fluid with a large molecule in it, and it's designed to promote the retention of fluid in that intravascular space. The most common colloid we use in the wards is albumin. Blood products are also important in surgery, but I think you guys will be getting a separate lecture on that, and it's sort of beyond the scope of this current lesson. So this table summarizes some important. So whenever you think about prescribing fluids for a patient, have the following paradigm in mind, and it's what I call the 4 R's. So firstly, think about if you have deficits that you need to replace. Next, calculate your routine maintenance, that is, the maintenance fluid patients need when they're not having anything orally. Replace any ongoing losses. For example, surgical drains may have a loss of pus or blood. You can have a high stoma output. You can be losing insensible losses of fluid with sepsis, etc., etc. And the most important thing is to constantly review the patient and see what their fluid requirements are and how they are responding to your fluid management. I'm going to start off with routine maintenance as I started earlier. That is how to prescribe fluids for the fasting patient, and then we'll develop on the other concepts from there. So, let's say we've got a patient who's going to be fasting for a short amount of time, that is a day or two. So what do these patients need? There are 4 core requirements. Firstly, they need 30 to 35 mils per kilogram a day of water. They need 1 or 2 millimole per kilogram of sodium, 1 millimole per kilogram per day of potassium, and about 50 to 100 grams a day of glucose. And that's to limit starvation ketosis. I'd like to emphasize that this is for short-term needs for fasting patients, and patients who are going to be fasted for a prolonged period of time. That is, patients who might be fasted for maybe 3 days or longer after surgery while a bowel anastomosis heals, for example, they'll need something called TPN, total parenteral nutrition. And this is a way of more completely supplying the nutritional needs of the patient. That's going to be beyond the scope of today's lecture, and it's generally not something that interns make decisions about, not at least without a senior guiding you very closely. So, with regards to prescribing maintenance fluids, I'm going to go through the main autopilot ways that we use on the ward to simplify things for you, and I'll illustrate to you why this works. Now, the proviso is it's not a good habit to have an autopilot way of prescribing fluids, but it gives you a good framework to start on, and it is something we all use on the wards. So there are three main regimens used for how to prescribe maintenance fluids. So let's look at regimen 1. Very simple. It's in an approximate 24 period of time, you're going to prescribe 3 bags. And the 3 bags are going to be 4% and a fifth. That is 4% dextrose and 1/5 of normal saline. 1/5 of 0.9% is 0.18%. And the first and third bags will have added potassium in it. Okay? For any given patient who's not fluid restricted because they're old, they have heart failure, kidney failure, or cirrhosis, you can safely run these fluids at a rate of 100 to 120 mL per hour. This will give you approximately a fluid regimen for 24 hours. And like I said, I'll come back and illustrate why this works. The second regimen that you guys might have heard of is known as 1 salty and 2 sweet. Basically, we give a 1 bag of normal saline and 2 bags of dextrose. And like the previous example, the first and third bags will have some potassium in it. And again, each bag for a typical patient who doesn't have heart failure, renal failure, cirrhosis would be 100 to 120 ml per hour. So let me illustrate why the autopilot way works, right? So remember these requirements, the 4 requirements we spoke about for a short-term fasting patient. So for our 75 kilogram male, if they require 35 mils per kilogram per day, that equates to 2,625 mils a day. And if you divide that by 24, is 109 mil an hour. They're going to need 1 millimole of potassium per kilogram. That's going to be 75 millimoles of potassium. And between 1 to 2 millimoles per kilogram a day of sodium, which equates to 75 to 150 millimoles of sodium. And then we have our glucose requirement highlighted there as well. First, let's go to regimen 1, the 4% and fifth. 3 bags, the first and third bag with added potassium, running at 100 to 120 ml an hour, like I described. Now, if we look at the 4 main requirements, we're running each bag at 100 to 120 ml an hour. And look at our target, it's 109. It's within that range. Next, potassium. We've got 30 millimole in our first and third bags, giving us 60 millimoles of potassium. And that's pretty close to our target of 75 millimole. With sodium, each bag has 30 millimoles of sodium in it, so we've got 90 millimole there, which is again within our target. And our glucose, we're going to get 40 grams in each bag, giving us 120 in total, helping us reach the target as well. So as you can see, our method gives us pretty close to the requirements we said we need. If we look at our 1 salty, 2 sweet regimen, again, each bag is going to run at 100 to 120 ml an hour, giving us our target. We've got 60 millimoles of potassium in total, 30 in our first and 30 in our third bag. With regards to our sodium requirements, you're going to get 150 millimole of sodium in your 0.9% normal saline bag. Recall the second slide I think I showed you with the properties of each type of fluid. And you're going to meet your glucose requirements with your 2 bags of dextrose. So again, this meets most of your required targets. For completeness, I wanted to illustrate another way of calculating your daily fluid requirements, and you will hear people talking about the 4-2-1 rule, especially in pediatrics. So what this rule is basically you need 4 mils per kilogram per hour for the first 10 kilograms of body weight. For the next 10 kilograms, so 10 to 20 kilograms, you need 2 mils per kilogram per hour. And for any amount of weight beyond 20 kilos, you add 1 milligram per kilogram per hour. So if you take a 75 kilogram male, for your first 10 kilograms, you get 40 mils. For your next 10 kilograms, you get 20 ml. And then for the remaining 55 kilograms, you have 55 ml an hour. And if you add 40, 20, and 55, you get 150 ml an hour. And note that this is between the 100 to 120 ml hour rate in our autopilot method. So it gives you pretty much the standard calculation. I've already highlighted this earlier, but I want to re-emphasize. You must go slower at rates in the elderly and patients with heart failure, kidney disease, and cirrhosis. The risk is you can easily cause fluid overload in these patients, and the feared complication is an acute pulmonary edema. If you go a bit low with your fluids, patient will become dehydrated and you can catch up. But if you give someone an APO, they can have a hypoxic arrest, and that's a bit harder to deal with. Things to be aware of. When you have patients with heart failure, make sure you know what their fluid restriction is and do not exceed that with your maintenance rate. In patients who have cirrhosis, don't use fluids with a high sodium content repeatedly. You will worsen or cause ascites. In geriatric patients, be gentle because they're more prone to getting overloaded. Okay, and we go at sort of 20 to 25 ml an hour per kilogram in these patients, and we reassess frequently to see how we're going. So remember that I said there were three main ways of charting fluids in an autopilot manner. The third way is the non-ideal way and the way you should avoid. Now, if I can give you an example of what happens in the ward, an intern will be approached by a nurse who requests him to chart some fluids for a patient who's fasting for an ultrasound, for example. And when not much thought is put into it, and we all do this, they chart a litre bag of normal saline and they leave it. Now, doing this over a short period of time is okay. The body has really good homeostatic mechanisms and it can deal with it. But the problem is, when a patient's fasting, if every single JMO in the hospital just randomly charts one bag of normal saline or one bag of Hartmann's, then the patient's not really meeting their daily requirements in an appropriate manner. And I'll illustrate why. So, problem one, each bag of sodium chloride, and remember Hartmann's has a similar amount of sodium as well, is going to give you about 150 millimole of sodium. If you multiply this by 3 bags, that's going to give you 450 millimole of sodium over 24 hours if you run it at 125 ml an hour, roughly 24 hours. Now, that's going to exceed our target by 3-fold. The second problem with repeatedly charting normal saline in particular is that the high chloride content has a high anion gap and it's going to cause a hyperchloremic metabolic acidosis. And acidosis is not good for the functioning of any of your enzymes, and it's not too good for the functioning of the coagulation cascade either, particularly bad in surgical patients who you don't want to bleed. The third thing is you're replacing none of your critical electrolytes, particularly potassium, so this can lead to arrhythmias or cause an ileus. The fourth problem is that it's got no glucose in it. So look, while it's not uncommon to see interns chart a bag of sodium chloride or a bag of Hartmann's without much thought, it's not something that should be done for a sustained period of time for these reasons. Next, we come to fluid resuscitating dehydrated patients. When we give fluid resus, we commonly give it as an intravenous bolus. The patients we give these to are patients who are significantly dehydrated and are hemodynamically unstable, that is, they're tachycardic, have low blood pressure, and they'd also have low urine output, indicating that perfusions to organs is suboptimal, or that your kidneys are forced to retain most of the fluid passing through them. The most common fluid type we use to resuscitate patients is normal saline, and the general principle is that you should use isotonic fluids that don't have too much potassium in them. We typically give a 500 ml stat bolus and reassess. You're supposed to reevaluate roughly around half an hour after each bolus and give a total of 1.5 to 2 litres at an intern level until the desired response is observed. So whenever you give a resuscitative bolus, you're looking for an improvement in heart rate, blood pressure, and over time an improvement in urine output, as well as these other measures. At a junior level, if you've given more than 1.5 litres or 2 litres, it's time to get some help from your registrar. In patients who've got heart failure, impaired kidney function, or are elderly, use smaller boluses. So I typically go for a 250 ml bolus in these patients. In patients who've got cirrhosis or other liver pathology, be very careful about using excessive amounts of normal saline. You'd find that people tend to prefer to resuscitate these patients with albumin fluids. So now I'll come on to electrolytes. The three most common electrolytes you will replace are potassium, magnesium, and phosphate. In the surgical setting where we try and optimize electrolytes to these levels, a simple rule to remember is a 4-1-1 rule, which is K4, Mag1, phosphate 1. This is going to be your target for almost all patients when you're employing either a cardioprotective strategy or you're using it as a strategy to optimize bowel function. But keep in mind that these targets are slightly above, in some cases, the normal range, but not significantly higher. We'll start off with replacing potassium intravenously. So whenever we use intravenous replacements, we make use of these mini bags. And there's different mini bags that are available. I'm going to talk about the ones that are most commonly used in Nepean Hospital, and I would imagine most other networks around Sydney as well. So for potassium, you basically get these small 100 ml bags that are made up of 0.29% normal saline, and they consist 10 millimole of potassium chloride. And you run these over 1 hour. In the non-HDU setting, you do not run potassium any faster than 10 millimole per hour, as you can cause cardiac arrhythmias. Each one of these 100 ml mini bags consisting of 10 millimole of IV potassium will increase your serum potassium by 0.1. So for example, if your patient has a potassium of 3.6 and you want to get the potassium to 4, you'll need to chart 4 of these mini bags. Many people come onto the surgical wards and don't realize that oral potassium is equally equivalent at altering the serum potassium concentration as well as IV potassium. And I've just included a snapshot of a journal article to illustrate this point. So just like earlier, if you want to improve your serum potassium from 3.6 to 4, you would need to give an oral replacement of 40 millimole in total. Your three most common oral replacement options are chlorvescent, which contains 40 millimole per tab, Slow K, which contains 8 millimole per tab, or you can just ask your patient to eat a banana, which contains 12 millimole in one banana. With magnesium replacement, if you want to replace it intravenously, we typically use 100 ml mini bags that are made up of 0.9% normal saline, and the additive is 10 millimole of magnesium sulfate. Your oral replacement option typically will be Magmin, and each tab contains 1.5 millimole of magnesium in it. So if you give 2 tabs, you can get 3 millimoles of magnesium. The mini bag for phosphate that we currently use at Nepean is slightly different. It's a 250 ml bag compared to 100 ml that was used in the previous two electrolytes. And it's got added 10 millimole of sodium dihydrogen phosphate. And because it's to a 250 ml bag, you run it over 3 hours. Each 10 millimole of IV phosphate should increase the serum phosphate by 0.2. So, just like to re-emphasize, whenever you think about replacement, consider replacing deficits. So replace your electrolytes, give statin boluses if the patient is tachycardic hypotensive. Calculate your routine maintenance as we described using one of our autopilot methods, and make sure you replace ongoing losses. And I'll provide you with an example on how to do that. Remember, it's very important to review your patient regularly and assess how they're responding to your therapy. I can't give a tutorial on IV fluids without including a little bit on fluid status. And the fundamental principles of history, exam, and investigation still holds. On history, I like to start about finding out whether the patient has a history of heart failure, kidney failure, or cirrhosis for the reason we talked about earlier. Ask about thirst, it tends to be a pretty sensitive sign. Find out how much they're eating and drinking. Ask about any vomiting and diarrhea. You subsequently would ask about questions screening for reasons why they might be overloaded or dehydrated. With the examination, you start off with the vitals, and then I like to have a peripheral approach where you go from your hands, arms, eyes, and so on. So I grab their hands, feel if they're warm peripherally, check their cap refill, I see what their skin turgor is like, I check their JVP, I ask them to stick their tongue out and see if they've got a wet coat or whether the tongue appears dry and cracked. I go for the lung bases, see if there's any crackles indicating pulmonary edema. I then look at peripheral and sacral edema. It's important to look at what previous IV therapy they've been on so you can assess how their response to that has been. Urine output's very helpful in guiding your therapy as well. And it's important in your surgical patients to check what's happening in the drains, the stoma output, and the NG output as well. If the patient's been getting daily weights and know their baseline, this can give you important information about their current fluid status. Don't forget about the medication chart and things like diuretics and laxatives or medications that can alter your electrolyte status are very important to know about. With regards to investigations, your EUCs can give you some good hints. So a patient who's dehydrated and has a pre-renal AKI brewing, they tend to have a raised creatinine. You can be hemoconcentrated, giving you an increased hemoglobin and hematocrit compared to baseline. In patients who are hypovolemic enough to give a pre-renal AKI picture, you'll get an elevated urea to creatinine ratio. If the hypovolemia is significant enough to affect organ perfusion, a VBG, that's a venous blood gas, can give you a lactate, which will be elevated in this setting. Compared to the list that I gave in the previous slide, it's helpful to think about what a wet patient and a dry patient sounds like. So your patient who's really dry and depleted, they're going to be thirsty, they're going to be tachycardic, hypotensive, they'll have a postural drop, and they're going to have some decreased urine output if it's significant enough. The mucous membranes will be dry, the skin turgor will be decreased, and the cap refill will be increased. And you're not going to have signs of fluid overload like a JVP that's elevated or pulmonary edema. Similarly, in a patient who's overloaded, you're going to get an increased rest rate and SpO2 at your saturation level if they've got significant pulmonary edema, and you'll have a raised JVP, they'll have peripheral edema, sacral edema, and evidence of pulmonary edema. And the presence of all these signs depends on the severity of the fluid excess or in depleted patients a level of dehydration. I've just included this slide here to highlight the nature of the fluid losses depending on where it's coming from. So let's look at this case. You're the ED intern working at night who works up a 65-year-old male who's had a mechanical fall on a background of vitamin D deficiency and osteoporosis. On exam, he has a shortened and externally rotated right leg. An X-ray reveals a right neck of femur fracture. His vital signs are all normal, his mucous membranes are moist, and his JVP is not elevated. Notably, the lung bases are clear and there is no peripheral edema. You call the orthopedic reg who's happy to admit the patient under their care. he asks you to ensure the patient is kept nil by mouth for theatre and to chart maintenance fluids. The patient's weight is 70 kilograms, the electrolytes are normal, and they have no other important comorbidities. What would you chart this patient? So it's important that you notice the previous patient was euvolemic, requiring just maintenance fluids, and they didn't need to have any replacements based on the information provided. So for a 70 kilogram male, if you go at 35 mils per kilogram per day, you get 2450 mil a day, which equates to 102 mil per hour. Now, if you use one of the regimens I described earlier, let's start with regimen 1. You use 3 bags of 4% and a fifth with potassium in the first and 3 bags as we discussed, and you've ensured your rate is correct. It would also have been fine to use the 1 salty, 2 sweet method as well at the rate provided, 102 ml per hour. So in this case, you've got a 45-year-old lady. So this patient has deficits that you need to replace, as evidenced by her hemodynamic status. I would normally give a 500 ml of bolus of normal saline and then reassess. So you've given your bolus, you come back in half an hour and reassess. And while she's had some improvement in her hemodynamic status, she still appears clinically dry. What would you do next? So given that she's dry and she's responding to your fluids, you give another bolus of 500 ml of normal saline. This takes your total to 1 litre in fluid resuscitation. You go back to reassess in 30 minutes and her vitals are all now normal. Her lung bases are clear and her JVP is not elevated, so you haven't gone too far and overloaded her. In this sort of patient, it would be reasonable to now chart her some maintenance fluids to run until her antiemetics take effect and she's able to tolerate some oral intake. I would also order electrolytes for the morning to make sure her electrolytes, especially her potassium, does not require any replacement. Have a look at this case and I'll go through it in the next slide. So the thing to be careful about in this slide is that it's an elderly lady who's frail. She's got acute delirium in the context of an intercurrent illness, which is her acute diverticulitis. Based on the information, she's clinically euvolemic and she's got a history of cardiac disease. And given that you don't know her ejection fraction, you need to be careful. It's easy to overload these patients, and remember, as we discussed earlier, to go gentle with the fluids. So I would go at 25 ml per kilogram per day, and this gives you roughly 62.5 ml per hour. So you can use one of the 2 regimens we described above. Slower rates at 60 ml an hour, first and third bags with potassium chloride. You can also use the 1 salty, 2 sweet method as well, which is regimen 2 of what we discussed earlier. It's important to review the clinical status of these patients. It would be wise to request nursing staff to keep a stick fluid balance chart, including measurements of urine output, as this will guide your future management. You can always start at basic rates based on your autopilot methods, but as long as you review, you can reassess and increase or decrease your rates as required. So in this case, we have a 65-year-old man who's being admitted under your team with an adhesive small bowel obstruction. Apart from a right hemicolectomy for a colon cancer 2 years ago, he's otherwise healthy. Although he's been having fecal and emesis for the past 36 hours, he has already been fluid resuscitated in the emergency department and is now hemodynamically stable with a normal blood pressure and heart rate. Your reg tells you that he's being transferred to the ward and asks you to optimize his electrolytes. Pause this slide and have a go at prescribing electrolytes for this gentleman, and we'll go through it in the next slide. So remember that patients who are nil by mouth and patients who have a bowel obstruction or ileus don't absorb anything given orally. So you need to, in this context, replace electrolytes IV. if you don't remember how oral or IV replacements equate to a change in serum levels, go back and have a look at that now because it's important to know those basic guidelines so you know how much of each mini bag to prescribe. So if you look at potassium, he's 3.6. Remember I said that some of the normal levels are less than the targets we talked about? Here's an example when you want to try and optimize electrolytes to K4 Mag1 phosphate 1. So you want to get his potassium from 3.6 to 4, so you need to chart 4 mini bags. Similarly, based on the amounts of oral replacement or IV replacements needed to change serum levels, you would give 1 or 2 mini bags of magnesium, because that each 10 millimole in a mini bag gets you up by 0.15. And for phosphate, you'd give 2 mini bags. Then you would prescribe normal maintenance fluids, review his fluid status, urine output, EUCs, and adjust and replace as necessary. For a patient with a bowel obstruction, don't forget to monitor NG outputs. These patients can have a lot of NG output, and it's not uncommon for them to need higher amounts of fluids. Let me quickly unpack that for you for a moment. So recall that we said for maintenance fluids, the normal rate is 100 to 120 ml an hour. Now, if you have a patient who's losing 100 mils through the NG tube every hour, I would add about 50 to 75% of that amount to your maintenance rate. So if I want to give a maintenance rate of 100 mil an hour and they're losing 100 mil an hour from the NG, I'd add 50 to 75 mil an hour to my maintenance rate. So I'd give a maintenance rate of 150 to 175 mils per hour. So this is going to be a bit more of an advanced case. With the surgical intern and your pager goes off for an urgent clinical review. As you walk into the ward, the nurse tells you the review is for hypotension. You have a quick read of the progress notes. It's an 80-year-old female weighing 80 kilograms. She's day 1, 20 hours post a laparotomy for a small bowel resection, a small bowel obstruction where 3 parts of necrotic small bowel was resected. The procedure took 8 hours due to the difficulty in performing the anastomoses. Her past medical history includes rheumatoid arthritis, urinary stress incontinence, multiple BCC excisions, but no other critical illness. Pause here and think about if you were to deal with this case, what you would want to know in history, examination, and investigations. So, you ask all the appropriate questions. When you arrive at the bedside, she appears lethargic, but is alert, oriented, and responding to your questioning appropriately. She tells you that she's feeling really thirsty. She's not had any chest pain and does not feel short of breath. The reason why we're asking that is we want to make sure the hypotension is not due to a myocardial infarction or a PE. She denies any abdominal pain, PR bleeding, melena, or infective symptoms. So the reason why we're asking is you want to make sure the patient's not bleeding. Whenever you have hypotension in a surgical patient, your first, second, and third differentials are bleeding, bleeding, and bleeding. You're asking about infective symptoms to make sure it's not a sepsis driving this picture. And remember, elderly patients who are septic don't always mount a febrile response. On exam, she's tachycardic, she's hypotensive, but her respiratory status appears to be okay, and she's not febrile. The GCS is 15, which tells you that she's still perfusing her brain okay, and she's still warm peripherally, so that's a reassuring sign that she's not shutting down just yet. But her tongue and mucous membranes appear dry, her skin turgor is decreased. There is no sign of fluid overload. Because you want to make sure the abdomen's okay, you examine the abdomen and you're reassured that it's soft without any signs of peritonism. Always check the surgical drains in patients who have one and you check in this lady and you're reassured by the fact that there's no blood. You double check that there's no conjunctival pallor or palmar-crease pallor indicating blood loss. Now you go and look at her charts. So since the operation, she's been receiving 65 ml an hour of IV fluids. Her abdominal drain has been 20 ml net since the operation, which is not too bad. Her NG output has been 100 ml an hour, which is completely expected for this sort of patient who's had a bowel obstruction and who now obviously is going to have an ileus. You note in the operation report, it says she's had a half a litre of intraoperative blood loss. Concerningly, her urine output over the past 4 hours has been very low. She's only made 300 ml of urine since coming out of theatre 20 hours earlier. You get an ECG to make sure nothing is wrong with the heart. An ECG can also give you signs of right heart strain if the patient's got a PE. She's got a sinus tachycardia, but no signs of heart strain, ST segment changes, or other signs of an ischemic process. You ask the nurse to do a bladder scan to make sure her catheter is not blocked, given that her urine output's been so low, and you're reassured that the bladder scan shows a lack of urinary retention. You go to the computer and check the morning bloods to see what's been going on today. You're reassured by the fact that the hemoglobin is normal, and the EUCs are shown on the right, which is somewhat concerning. What do you think is going on in this patient? So all the evidence suggests that this patient is severely volume depleted, and this has led to an oliguric acute kidney injury, which appears to be pre-renal. Now she's been getting 65 ml of fluid per hour. Now, someone's presumably looked at her age and charted a reduced amount of fluid per hour, which is somewhat reasonable given that she's an elderly patient. If you look at the net input and net output, you found that her input 65 ml an hour. Remember, this lady's 20 hours since the operation has ended, so that gives you 1.3 litres of net input, and she's not eating or drinking, so it remains at 1.3 litres. But look at all the losses that you found on her history. So patients going open laparotomies lose 1.5 ml per kilogram per hour. So over an 8-hour operation, she would have lost 960 mils. Recall that the operation report noted she had an intraoperative blood loss of 500 mils. She's having 100 ml an hour from her NG tube, and that's 2 litres since the operation. And her post-operative urine output's 400 ml. So, assuming that the anaesthetist has dealt with the intraoperative blood loss as well as the insensible losses during an open laparotomy, you've still got a total output of 2.46 litres. Now, if you calculate your net fluid balance, this lady is in a negative fluid balance of greater than 1 litre. Given that she's also had an urgent laparotomy for a bowel obstruction, we don't know how fluid depleted she was before going into theatre. Presumably, she would have not been eating or drinking as well as vomiting before the operation, so her true net fluid balance is probably greater than this. If you think about how you would treat this patient, so given that she's hypertensive, tachycardic, you're going to have to give some boluses. So I'd give 500 ml at a time, up to 2 litres, until her hemodynamics improve. It would also be not a bad idea to do an ABG or a VBG to obtain a baseline lactate so you can monitor the biochemical response to IV fluid therapy. Remember when you're giving fluids boluses that it's not just about a number, you're going towards a goal. It's goal-directed fluid therapy. And what you want to see is improvement in heart rate, blood pressure, especially in the short term, and over the long term, you want to see improvement in her urine output. Now, she's been getting fluid at 60 odd ml an hour, and you need to increase the maintenance rate as highlighted earlier, based on average losses over the past 4 to 6 hours, especially given that she's got high NG output. So if she's losing 100 ml per hour via her NG tube, I would think about adding probably half to 3/4 of this to the ongoing maintenance rate. I'd need to, because she's critically unwell, you'd need to review this patient every couple of hours and make sure that she's responding to your fluid therapy, seeing what other ongoing losses are noticeable, and replace as needed. It's an unwell patient you've got on your hands here, and it's someone you need to review at a fairly frequent basis. And this is a type of patient where you will inform your registrar and get some support as an intern. The reason why I highlighted this case is not only is it a real case that I came across on the wards, but it's to highlight that you need to replace your deficits. You need to replace ongoing losses, especially in surgical patients who tend to have a lot of these, and review your patient frequently to make sure they're responding and trending in the right direction. Given appropriate routine maintenance, it's okay to go slow in an elderly patient, but if you review this patient, you can see that the urine output's not great. You'll notice that the hemodynamics are starting to drop, and you can adjust this. So, some final take-home messages. Remember the 4R approach. Replace deficits. That is, if they're in a negative fluid balance and they're tachycardic and hypotensive, give some fluid bolus. Replace electrolytes as well if they're abnormal when they come in. Calculate your routine maintenance via the methods described. Review your patient and replace ongoing losses. Now, I didn't mention this earlier, but for patients who are obese, adjust their fluid rate based on their ideal body weight and use lower range volumes per kilogram. It's very unusual that a patient should require more than 3 liters per day. If they're really obese, get some input from your registrar as to how to chart fluids. Sometimes you will chart fluids for patients who are on TPN. For these patients, find out what rate the TPN is going at and subtract this from your maintenance rate. So for example, if your calculated maintenance rate is 120 ml an hour and TPN is running at 50 ml an hour, run your fluids at 70 ml an hour. Don't forget, always ask patients whether they have heart failure, chronic kidney disease, and cirrhosis. Prescribe slower rates for patients who are old, frail, have heart failure, or chronic kidney disease. And for patients who've got cirrhosis, avoid sodium-rich fluids. Remember that these patients will generally require albumin. The first time you need to do this on the ward, get help from your registrar. The final message about patients with chronic kidney disease, they tend not to clear potassium as well. So reduce the amount of potassium you give these patients as you don't want to cause a hyperkalemia. I hope, as promised, I've given you guys somewhat of a framework to deal with IV fluids. I'm happy to get some feedback from you guys, and if you have any questions, I'm really happy to be contacted on my email. Thanks guys, hope it helped.